All right, and so today we're picking up from the presentation that I did back in January, I believe, regarding the NICE guidelines. And the NICE guidelines are the UK's version of the GOLD guidelines. And specifically what it is it is a set of guidelines used to diagnose and manage patients that are over 16 years old in the United Kingdom. And so what we had covered the last time was the diagnosis and also managing stable COPD. And as we went through, I did sort of mention a little bit about the differences between the GOLD guidelines and the NICE guidelines. And so where we left off was at managing exacerbations. And so I will go ahead and pick up there and finish out the presentation and then sort of wrap up with some similarities and differences between the two. So you can go ahead and go to the next slide. Oh, let me, hold on, I see everybody's face over here on the side. I'm gonna just minimize you all so I can see the slides. All right, so the definition of an exacerbation is very similar to the GOLD guidelines definitions. It's a sustained worsening of the patient's symptoms from their usual stable state, which is beyond normal day-to-day variations and is acute. So as we all know, with our COPD patients, they do vary from day to day. You know, they may have a good day in the morning and then their afternoon gets worse, or vice versa. They may have intermittent episodes of worsening throughout the day. But what we're looking for is something that is sudden in onset, that is more severe worsening than what their normal day-to-day variation is. We can see them having breathlessness, cough, increased sputum production, and a change in sputum color. And oftentimes this exacerbation or this worsening of symptoms will require that they use more than their normal amount of medications. Next slide. This particular guideline is provided for their medical professionals in the UK about whether we treat these patients at home or whether we treat these patients in the hospital. And as you can imagine, patients that are more severe, that have more symptoms, that don't have as much support are probably people that need to be treated in the hospital. If the patient's symptoms are mild, they're generally in good condition, you know, their activity may be a little bit limited, but they're still able to sort of keep up with where they were. Those patients can be treated at home. Any alteration in their level of consciousness, or if they're already on supplemental oxygen, those patients are recommended to be treated in the hospital. Again, if they don't have any social support at home, those patients should probably also be treated in the hospital just in case of an acute decompensation. And then down at the bottom, you know, if their oxygen saturations are less than 90%, if they've got changes on their chest x-ray, if their pH is increased or their PaO2, I'm sorry, if their pH is decreased or their PaO2 is decreased, those patients should also be treated in the hospital. Next slide. So remember that the medical system in the United Kingdom is different from ours in that primary care physicians do treat a majority of these patients, only referring them to specialists when they get a little bit more severe or you know, a little bit past what the primary care provider may be comfortable with. So most of these patients are managed by their primary care provider. They do state that there's not really a benefit to getting a sputum culture, which we have seen here in the United States, that most of the time we're actually not going to grow anything, or it'll be a contamination. And so we treat without getting a culture. Again, they do recommend to use pulse oximetry if there are features of a severe exacerbation, which is similar to how we manage here in the United States. And that would be outpatient management, sorry. As far as hospital management, these patients should have chest x-rays, blood gases, EKGs, blood counts, kidney function measurements. If they're on theophylline, you should measure their theophylline level. If their sputum culture in a hospitalized patient is purulent, they should if their sputum is purulent in a patient who's in the hospital, they should have a culture. And if they do have a fever, they should get blood cultures. Next slide. So one of the differences in the healthcare system in the United Kingdom versus our system is that they have this thing called hospital at home and assisted discharge schemes. And I think, you know, the assisted discharge schemes is probably similar to our home health, but the hospital at home is a little bit more intensive. And this is a safe and effective and an alternate way of caring for patients with exacerbations who otherwise would have needed to come into the hospital. And this includes nurses, physiotherapists, occupational therapists, and others. But there's not really a clear set of guidelines about who is most appropriate for this and who does need to be in the hospital. But I think this is a little bit more intense than just getting a home health nurse or home health physical therapist or occupational therapist to come into the home. This is something that's a little bit more presence in the patient's home. Next slide. So pharmacologic management of these patients is first off going to be increased doses of their short-acting beta agonist, which is their albuterol or their Xopenex. You can use either nebulizers or handheld devices, depending on the patient's ability to use the device and the resources available to make sure that the patients are getting their medications correctly. They did mention that if the patient is hypercapnic or acidotic, nebulizers should be driven by compressed air rather than oxygen to avoid worsening their hypercapnia. They also recommend the use of oral corticosteroids in conjunction with other therapies in patients that are hospitalized. And in community patients, if they have an increase in their shortness of breath that interferes with their daily activities. The recommended dose in the UK Respiratory Society is 30 milligrams of prednisone daily for 5 days. If you look across the board, they've done multiple studies that have shown that there is no set consensus on how much prednisone anybody should give. Most of the societies here in the United States recommend 40 milligrams a day times 5 days. Theirs is 30 milligrams a day times 5 days. I don't know that there's been any there hasn't been any studies that have shown, you know, one is more beneficial than the other. We do know, though, that a shorter course is just as beneficial as a long course. They studied a 2-week course of steroids versus an 8-week course of steroids and did not find any benefit in that. The only detriment they found with that was that there was more side effects in the patients that took the steroids for the longer course, including increased blood sugar. So short, but a little bit of a higher dose and no taper needed. Next slide, please. This table talks about first choice of antibiotics, which is either empirical or guided by their most recent sputum culture and susceptibilities. Their first line is amoxicillin, doxycycline, or clarithromycin. Their second line is also amoxicillin, doxycycline, or clarithromycin. So if you fail the first, you've taken antibiotics for 2 to 3 days, have not seen any improvement, they recommend switching to another one within that class. And then beyond there, they go on to open this up to some other categories. Levaquin, which we see often here, is their third tier. And then Zosyn would be, I'm assuming, just for hospitalized patients because it is an only IV, which is down at the very, very bottom, the piperacillin with the tazobactam. Next slide. So there was some mention in the NICE guidelines of using theophylline, and this is not for patients who are already on theophylline, but used as an acute management for these patients if the patients do not receive adequate response to nebulized bronchodilators. They do recommend using or adding theophylline for the short term. Another medication that they recommend adding is a respiratory stimulant called doxapram, and this is only when non-invasive ventilation, so the CPAP, the BiPAP, is unavailable or is inappropriate for the patient. So the non-invasive ventilation will still be first line for this particular group of patients. Next slide. Similar to our guidelines here, you would use oxygen as needed to keep your saturations within the target level. That was all the more specific they got. They did not recommend a target level, but I believe it would probably be the same as ours, keeping saturations greater than 88%. Recommend measuring arterial blood gases regularly and according to sort of follow up on your treatment and whether it worked. If patients have a persistent hypercapnic ventilatory failure despite optimal medical therapy, consider non-invasive ventilation. And this should be delivered in a dedicated setting with trained staff and with a clear plan in place in case there is deterioration. They also recommend using the ICU as needed, but they want you to consider the patient's functional status, BMI, need for oxygen when stable, comorbidities, previous ICU admissions, age, and FEV1. And so they also do recommend that if you've got somebody who is slow to wean from invasive ventilation, consider not even going that route and using non-invasive ventilation instead. And again, in the United Kingdom, their treatment plans are oftentimes driven by socioeconomic availability of resources. Next slide. So monitoring for recovery requires regular clinical assessment of symptoms and functional capacity. Use pulse oximetry for patients that have non-hypercapnic, non-acidotic respiratory failure, and intermittent blood gases for patients with hypercapnic or acidotic respiratory failure. Do not routinely perform daily monitoring of peak expiratory flow or FEV1 to monitor their recovery. Next slide. Discharge planning, they do recommend that all patients should have spirometry prior to discharge. You need to reestablish the patient's home medication regimen before discharge. They need to have either satisfactory oximetry or blood gases. They need education on medications and oxygens, especially anything that is new. And then they do need arrangements for follow-up to be made. Next slide. So some of the interesting points, this is my first summary slide. I went back through, in preparation for today's talk and got a couple other talking points. But what was interesting to me the first pass through was that in the UK, they do recommend to start screening at age 35. We don't necessarily do any screening here in the United States. Usually our patients present to us with symptoms before we start to screen them for COPD or other respiratory diseases. They also recommend not performing reversibility testing or, to see if there's a bronchodilator response. But then further on in the guidelines, they go on to say that they use their reversibility testing to determine the severity of their COPD. So that sort of contradicted themselves there. And it seems like if you're going to treat these patients appropriately, that you should get the reversibility testing. Difference in their spirometry is that they use the 400 mLs as a criteria for reversibility. We use 200 mLs as a criteria for reversibility. So if you think about this logistically, we are going to see probably more patients that are considered to be reversible since our criteria is lower than theirs. And so they're going to have more patients diagnosed with COPD, where ours may be diagnosed as asthma because they do meet that reversibility criteria. They are very strict in the United Kingdom about who can get oxygen. Specifically, they say that smokers and patients who need only nocturnal oxygen should not receive supplemental oxygen. And then they also do not recommend treatment for alpha-1 antitrypsin deficiency. Next slide. Okay, and then, like I said, I did go through with a second pass last night and just wanted to sort of summarize some of the other changes or differences between the two sets of guidelines. And so the most current set of guidelines for both was really put out in 2018. Now, GOLD does update theirs every year, so there's some small changes here and there every year, but the last set of really updated guidelines was in 2018. The guidelines are really pretty similar. What they say is that making you need to make the diagnosis using a very good history. You need to do a good physical exam to look for other possible diagnoses or other things that this could be related to, other comorbidities. You also need to get a chest x-ray and do other appropriate testing as warranted. From there, if your diagnosis still looks like it's going to be COPD as your primary diagnosis, you need to send the patient for a set of quality assured spirometry. If this shows obstructive disease, then it is the diagnosis of COPD is made. From there, the treatments through both guidelines focus on smoking cessation and prevention by giving pneumococcal vaccines as well as influenza vaccine. They both recommend pulmonary rehab, and they say that pulmonary rehab should be a structured education program as well as personal exercise. And the goal of the pulmonary rehab programs is to improve the quality of life as well as their functional distance that the patients can walk. They also, both plans recommend developing a supplemental plan to give to patients to say, if things get worse, this is what our next step is going to be. They also both recommend managing the patient's comorbidities, so managing their heart disease, managing sleep apnea, managing anything else that may exacerbate or worsen their respiratory status. Both do recommend treating very similarly. They state that the patients will have exacerbations, and at their presentation to a physician, they become less active, and then they recommend, you know, starting treatment for these patients. The major difference in treatment between the two is that the GOLD guidelines recommend your LAMA as your first choice, so your anticholinergic, something like Spiriva or Incruse would be your first line therapy, versus in the NICE guidelines, they recommend a LAMA-LABA combination, so a long-acting muscarinic and a long-acting beta agonist combination. And these would be medications such as probably Anoro and Stiolto are probably the two most common combinations that we see here in the United States. And the reason, again, goes back to cost economics in the United Kingdom, that with a combination, you're going to get more bronchodilation, you're going to improve the symptoms quicker, and you're going to decrease the exacerbation rate. So this is going to cut costs for the United Kingdom healthcare system. And so they start right off the bat by using a combination medication and not messing around with a single agent here and a single agent there. They want to put the two together. And so that's probably the biggest difference, other than the ones that we've just discussed, between these two guidelines is the treatment right off the bat. And then if there is any component of asthma, they both do recommend adding the inhaled corticosteroid to that regimen. So that is all I had, just to finish up that presentation from January. So I'm happy to open it to any questions that anybody may have. I'm happy to go back over some of the previous slides that I discussed back in January, or talk about anything else. Thank you.
Awesome. Thank you so much, Dr. Sela. That was amazing. And thank you for those updated summaries as well at the end there.
And I can send that on. I can put that in a nicer format and send it on to you rather than my chicken scratch.
That would be perfect. I can put it in the recap as well. So yeah, any comments, questions, thoughts for Dr. Sela? Feel free to use the chat feature as well if audio is an issue.
Okay. Well, I did want to sort of update the group, since I have the floor, I guess, is that we are hoping, fingers crossed, to be able to restart our pulmonary rehab on Tuesday. So we have been running our cardiac rehab for about 6 weeks. So we're hoping to open it up to pulmonary rehab this week and see how it goes. We have plans in place for an appropriately social distance education session with patients on Tuesday, and then we'll start with exercise on Thursday. And at this point, we've decided to just do one patient at a time, with an appropriate time in between to clean our equipment before we bring the next patient in. All of our patients have been chomping at the bit to get back. We have one patient who has chosen not to come back. She just doesn't feel safe, doesn't feel comfortable. And so we've, you know, have told her that's fine. And so, you know, all of the patients are well aware that things could change at any point in time, especially with the recent uptick of cases in Preston County and Mon County.
It's exciting, though, that you guys are reopening back up. I believe Beth had a question, but she may be chatting it in shortly. I chatted her. So, Beth, do you want to try asking your question again? The audio was slightly in and out there.
I was curious about, can you hear?
Yes.
Can you hear me? Okay. I was concerned why they are so strict on the oxygen guidelines in the UK. Is it monetary, or what's their basis on such strict guidelines for oxygen therapy?
Yeah, most everything they do is based on cost economics, and you know, they're very, not only oxygen but also ICU beds. They have a strict age cutoff for ICU beds about who can go in the ICU. If you have had a recent trip to the ICU in a certain amount of time, they don't give you another ICU bed. And so all of this goes back to cost economics, and I believe the oxygen is the same way. You know, there's lots of upkeep and cost related to that is covered by the government. And so they're very stringent about who gets that and who doesn't.
Thank you.
Thank you. There was another question through the chat asking, with the NICE guidelines, do you see any similarity with those guidelines and COVID patients?
I think it's sort of hard to compare the two. The NICE guidelines being specifically for COPD. You know, I think you'd have to treat and evaluate the COVID patients within the limitations of the NICE guidelines. If they're having, you know, if they test negative for COVID, obviously, you know, you'd be more likely to be treating a COPD exacerbation. And so you would treat it with the steroids and the antibiotics. So I think, you know, it all comes back to COVID testing and knowing exactly what we're dealing with for these patients.
Great, thank you so much. Any other comments, questions? We do still have about 30 minutes left of this. I don't want to hold you guys here, but of course, as always, if there are any questions after the fact, feel free to email me and I'll make sure to have them answered and sent back to you. All right, well, thank you so much, Dr. Sela. That was excellent. I'm so excited that that PowerPoint was wrapped up today. So we really appreciate that. We'll see you all next time. One quick announcement. Our next session will be on July 20th, and Sunil Sharma will be providing our didactic on reopening from COVID. So thank you all, and we will see you guys next time. Thanks. Bye.